Good afternoon. My name is Petra Gooyens. I'm the Deputy Head of Unit of the Combating Diseases Unit in DG RTD. So again, good afternoon, everybody. You're very welcome to the Prevention, Early Detection and Screening Cluster Policy webinar. Under the Prevention, Early Detection Cluster, we have projects on screening, implementation research, and behavioral change. Today, we will be presenting only the screening projects. In 2025, we will have the second part of the Prevention Early Detection Cluster Policy webinar, where we will be showcasing the implementation research and the behavioral change projects. I would like to thank my colleagues in the Cancer Mission Secretariat for organizing today's webinar, which was a great team effort, as well as the Cancer Mission Board members and HADEA colleagues for the valuable input. I would also like to thank our hosts, Abigail and Clementine, from the Health Policy Platform for all the support and assistance, and Justine from the EU Cancer Mission Support Consortium. Before we begin, I want to let you know that you, the audience, will have several opportunities to participate and ask questions during the panel sessions. As we have 20 minutes for audience participation during each panel session, we may not be able to answer all questions or allow everyone to speak. However, we will answer all questions in writing which have not been answered yet during the panel sessions. We ask you to limit your questions and comments to the theme of the webinar or panel content. But first, we have a question for you. What do you expect from this policy webinar? We will use the poll function of WebEx to ask the question, and I will ask Justine to introduce this. Justine, over to you.
Yes, thank you very much, Petra, and good afternoon, everybody. My name is Justine van der Veen from PredictBio and the EU Cancer Mission Support Consortium. And as Petra already mentioned, is that we also want to hear about from the participant, from the audience, what you think, and there's also opportunities to participate and ask questions. So if you see in the WebEx right down, you will see 3 dots. And if you click on these 3 dots, you can select polling, but also Q&A. And as mentioned before, this Q&A feature is used for really content-related questions during the panel sessions later on. But for now, I would request you to go to the polling feature. And there you can select the answer, because we also want to know, what do you expect from this policy webinar today? So the first option is that you would like to get a better understanding of the Cancer Mission concept, or to hear about which project have been supported so far and what to come next. Or the other one is if you're interested in establishing contacts with other cancer stakeholders for future collaboration. So if you see those 3 dots, you can start submitting your answer. And then, as also stated before, if you have questions, you can reach out to the support. Thank you very much, Petra.
Okay, let's wait a moment when people are starting to do the polling. Okay, the results are slowly coming in. It looks like you still have to wait a bit, Justine, or can I call it a winner?
I think it's, as far as now, the winner is option B.
Yeah, exactly.
To hear about the project and what to come next.
Okay, thank you very much for voting. So I would like now, for the opening remarks, I would like to hand over to Joanna Drake from the European Commission. She's the Deputy Director General at DG Research and Innovation, but also the Cancer Mission Manager. Joanna, the floor is yours.
Thank you so much for inviting me, first of all, for this webinar. Let me first of all warmly welcome all of you to our second policy cluster webinar organized under the EU Cancer Mission, since it was launched in September of already 3 years ago, 2021. And it seems that a lot of people have registered for today's webinar. It shows a great interest in the Cancer Mission and the project clustering work. Last time I was told it was about 400 people. There might be more. So welcome, really, all of you. Together with the Europe's Beating Cancer Plan, the Cancer Mission aims at improving lives. The lives of everyone, if possible, but we have made a target of 3 million people by 2030. And I think that's quite measurable and it's quite definitive. And we want to save and improve their lives through, first of all, preventing cancer, having cures, access to cures, and also for those affected by cancer and their families to live longer and better. Using mission project clusters allows us to bring together research, innovation, citizen engagement, and public health policies to translate research into tangible solutions for citizens at risk of cancer as well as patients. Now, to ensure that scientific knowledge gained through research systematically informs policy choices, we have established joint dialogues at EU level amongst the health and research ministries, as well as among stakeholders from different disciplines and sectors. It's an integrated approach, and I think this really lies at the core of the Cancer Mission making an impact. And it is this approach that has been instrumental in shaping the Council recommendation on cancer screening, which was revised 20 years after its first adoption in 2003 to reflect the latest scientific evidence. So I think a sign of the Cancer Mission impact is exactly this change of a Council recommendation, which was already nearly 20 years old. Now, equally, this approach supports a successful implementation, which requires both the development of innovative screening methods and technologies, tailored policy choices, as well as leveraging of funds. Now, here comes a few numbers. We have 360 million euros allocated between 2021 and 2023 via the Cancer Mission. And a total of 2 billion euros have been spent on cancer research and innovation after only 4 years into Horizon Europe. The EU's commitment to cancer research and innovation, I think, have never been stronger and have never been visible as they are through the funding and through, hopefully, the impact. These efforts have now been reinforced in the mission letter to Ms. Zaharieva, our new Commissioner for Startups, Research and Innovation, and she is tasked with even intensifying further the efforts to make sure EU missions achieve their goals by 2030. Now, let me say a few words on why we have created these mission clusters in the first place. First of all, we wanted to build mission portfolios. 4 project clusters have been set up to engage coordinators in building synergies amongst projects, conduct joint activities, and deliver policy feedback. These activities have broadly mobilized the cancer research community as well as other cancer stakeholders and has engaged them to start implementing the mission's objectives. The purpose of today's webinar is actually to bring together the stakeholders and the citizens' perspectives on research, on innovation, and also on public health policy to provide an early exposure to the project clusters launched under the Cancer Mission, to other researchers, to other healthcare providers, to companies, and also to policymakers and citizens. With new projects under the Cancer Mission, we launched the first Cancer Mission clusters in September of 2022. And the purpose here was to build a portfolio of projects that address each of the 4 Cancer Mission objectives, as well as transversal Cancer Mission priorities, such as innovation, citizen engagement, childhood cancer, personalized medicine, and the inequalities, which of course sadly still exist. This is why we have established 4 clusters, one on understanding, which includes projects funded under the Cancer Mission in the area of risk factors and determinants, and in the area of tumor-host interaction. The second cluster relates to prevention and early detection, with projects on primary prevention implementation research and behavioral change, as well as screening and early detection. Today, we will be focusing on the projects addressing screening and early detection. The third cluster is on diagnosis and treatment, which includes pragmatic clinical trials on refractory cancers and diagnostics to achieve treatment optimization that can be quickly taken up by national healthcare systems. The fourth cluster is on quality of life. The goal of these clusters is to maximize the investment the EU Cancer Mission makes in research. Researchers who lead the projects are asked to build synergies among projects and conduct joint activities to ensure everyone can benefit from each other's insights. This activity will ensure coherent messages are brought to the cancer research community at large about what research and innovation can do to benefit them and their work. Clusters will contribute to testing how we can use the results from the cancer portfolio to provide feedback to policy and to inform cancer-related policy and research activities the EU should focus on. We believe by clustering projects, it improves communication, citizens' engagement, and also helps to achieve the early impact of project results, which we all hope for and which we shall be actually exploring. During the webinar this afternoon, we have two panel discussions. First, we invite you to an exchange on innovation in cancer screening and new technologies, as well as first impressions from working in the prevention and early detection project cluster. Secondly, we invite you to reflect on early cancer detection in prevention and early detection cluster projects and other EU-funded and national projects. We are looking forward to a lively discussion with all of you online today. The panels are made up of coordinators of screening projects from the prevention and early detection cluster. They will be joined by other stakeholders, such as coordinators from the EU for Health screening project, a Horizon 2020 funded project, an SME, which is a partner in one of the Cancer Mission projects, as well as a national project on screening, policymakers, and patient organizations and charities. With today's webinar, we will continue a series of webinars we intend to organize for each cluster area in the course of 2025. I wish you very fruitful discussions. Thank you.
I would like now to hand over to Philippe Roux, who's the Head of Unit for Cancer, Health and All Policies in DG Health and Food Safety, European Commission. Philippe, the floor is yours.
Thank you very much. Dear colleagues and dear audience, because of course, a lot of you are online for this webinar. It's also a warm welcome to it on behalf of DG Santé. Dear Joanna, you have already underlined how important the collaboration between the Mission on Cancer and Europe's Speeding Cancer Plan is. It is central, bringing together member states, stakeholders, and Commission services involved in the implementation of the Cancer Mission and the Cancer Plan in a unique collaboration effort has proven to be very beneficial. This allows us to tap into many useful synergy. We saw this morning into another discussion with the cancer subgroup. I mean, it's incredible. The project cluster, which have been set up under the mission, broadly align with the Cancer Plan main pillar, which are, as you have mentioned, prevention, early detection, diagnosis and care, and quality of life of cancer patients and survival. This reflects well our common priorities. As you say, cancer screening and early detection is indeed a prime example of our collaboration and of how scientific research can inform policies, because we are here at a crucial point, how scientific research can inform policies. The scientific opinion of the groups of chief scientific advisors developed through the Commission's advice mechanism has decisively informed the development of the new Council recommendation on cancer screening. It was adopted, you will remember, in December 2022, contributing to the Cancer Plan flagship initiative to set up the new cancer screening scheme. The Commission has provided targeted funding through the EU for Health program also to support member states in further stakeholders in implementing this Council recommendation. So a lot has been invested. Again, I'm counting here on many possible ventures to generate synergies between research and policies. Because here, the term synergy take all its sense. It is really synergy between research outcomes and policy development. Many promising research projects funded through Horizon Europe will provide further scientific evidence on how to improve and extend cancer screening programs, and that's for us essential. This today's webinar provides an excellent opportunity to bring these projects together, and I'm pleased to see that we have also 3 EU for Health projects presented. We will later hear more from the CanScreen ECIS. This project has worked on refining cancer screening performance indicators and on developing a data submission portal for cancer screening data. The result and follow-up work will allow for better monitoring and consequently more targeted quality improvement of cancer screening programs. The floor will be also given to representatives from Solace and PraiseU, 2 projects which are working on testing and developing innovative approaches for lung and prostate cancer screening. These projects are therefore directly contributing to putting the provision of the Council recommendation on cancer screening into practice. And remember, they come from the SAM opinion. So the link between science and concrete actions here is made, and you will see some of the outcome already. And I'm really looking forward the following interventions, and I wish you also a very useful and interesting webinar. Thank you very much.
Thank you very much, Philippe. Now I would like to ask Harry de Koning, who is Professor of Public Health and Screening Evaluation at Erasmus University Rotterdam, to give a short overview of the state of play of cancer screening. Over to you, Harry.
Good afternoon. Thank you so much. Thank you so much for inviting me. I hope you can all hear me good enough. With the difficult task, of course, to give a short overview over all what is happening in the EU on this important field. Nevertheless, I'll try to give you some hot shots on the risks and benefits of cancer screening programs in the EU. Let's see whether it works. Yes, it works for me, at least. I can see the slides. It's clear cut that in order to have a screening program, these are the criteria that we are looking at nowadays. You have to have substantial positive health outcomes, and they may be different outcomes depending on the type of disease or the type of screening you do, but nevertheless substantial positive health outcomes, preferably established in randomized controlled trials first. There should be limited adverse side effects, hopefully, and you have to estimate these adverse side effects so that you know what the balance between risks and benefits are at the start of your program. Finally, of course, there should be a reasonable balance between costs and benefits, and it, of course, has to not change in the nearby future differently, let's say, than what you had expected, of course, or that there will be unintended effects the moment you start. Anyhow, these are the major criteria. Unfortunately, I think in many of the programs we do, there are important side effects. False positives, the early knowledge of the diagnosis as such is a side effect. Of course, you have to go to hospital for more times for visits, etc. There are longer time of side effects of treatment, of course, with a good goal, but nevertheless, you have to quantify this as a side effect to some extent. You may be detected earlier, but you have no benefit. You may be diagnosed with a disease that you would otherwise never have been diagnosed with. Because of, for instance, due to comorbidity or so. There may be risk of screening and assessment. There may be possible false reassurance. You have a negative test, you have symptoms, and you do not go to the GP. Or you may be even say, okay, my test was negative, so I can now really take up bad habits. So surely important side effects that we have to take into account, but fortunately we are doing that. So what do we now know about the running programs in the EU? I think the handbook on breast cancer screening, if we start with breast cancer first, we clearly show that there are trials that showed efficacy. That is the green part that says sufficient evidence for women aged 50 to 69. But now more and more there is effectiveness evidence. So meaning basically in the running programs, we have enough sufficient evidence on breast cancer mortality reduction in the 50 to 74 years age range. Those are the green columns. And more we get enough evidence to say that 45 to 49, this is the overview in 2015, but now we would certainly say 45, 49, we again have enough evidence on benefits. And basically it means, this is sort of summary, it means that if a woman attends mammography screening, she has a 40% reduced risk of dying from the disease. In a recent review by a PhD student of mine, Nadine Zilonke, published in European Journal of Cancer, you really see all these high-grade quality running programs with their evidence, and basically you should see all the point estimates on the left-hand side, clear reductions, and again, basically something in the order of 40 to 50%. What would that mean here in the Netherlands? A summary for the Netherlands. On the left-hand side, you have 1,000 women without screening, and unfortunately, there will be then 45 women dying from the disease. But with the screening program we have in the Netherlands, this will fortunately be reduced to 32. So 13 out of 45 will not die from breast cancer anymore due to the screening program. There are those blue or purple circles being false positives, and there are those 5 black dots, unfortunately, 5 women who unfortunately are being diagnosed with breast cancer, are being treated for breast cancer, but without the program, they would not have been diagnosed with the disease. And this is the balance, this is the unfortunate balance, let's say, we have to tackle. But again, we would say this is a reasonable balance. This is why we do the screening program in Europe, basically. So as an estimate, for instance, we say in every 3 women who will not die from the disease anymore, unfortunately, there's 1 woman being overdiagnosed. But without overdetection, there is no benefit. This is the unfortunate balance of screening. An earlier detection also means some overdetection in some women. Nevertheless, we did an analysis. What does it mean for Europe? And in this paper, or the potential breast cancer screening in Europe, we estimated that every year almost 22,000 women are not dying from the disease anymore due to you or due to all the screening programs we have. We could still improve it. We could still improve it with about like 10,000 individuals or 12,000 individuals not dying anymore from the disease. So yes, there's still things to do by innovative tests, by personalization, etc., by a higher coverage or by more screening programs at high quality. There's a big debate sometimes whether it's all not due to treatment. We see important reductions in breast cancer mortality. On the left-hand side, is the graphs are from a US paper, and basically what you see, if you see the blue line or the purple line going up, that would be breast cancer mortality without any screening programs, without any treatment improvements. But with the screening program and with the treatment improvements, we basically lower these. We lower this line importantly with about 50% or 60-40% or so. And in fact, in the JNCI 2011 on the right-hand side, you see the reference to it. In fact, just screen detection as such is now really an independent prognostic value for a woman being diagnosed with breast cancer. So in breast cancer, clear-cut evidence, also less mastectomies, also less adjuvant systemic treatments. What about colorectal cancer? Colorectal cancer, of course, different tests being used in different member states and a much more newer program. And that means that the amount of evidence is still more limited, of course, than, for instance, the breast cancer screening programs. And so you can look at the intermediate outcome measures. For instance, do we see lower incidence of colorectal cancer in countries where screening has started? Do we see a reduced incidence of advanced stages? Do we see improved treatment options? And so there are sort of intermediate outcome measures that we can look at. And again, I give you some Dutch examples. They are maybe exemplary. Of course, there's much more out there, and that, of course, we see in the reviews. But what we see here, we see lines of incidence based of advanced disease. And in each cohort that was invited either in 2014 or 15 or 19 for the Dutch program, we see at some point increases in the detection of advanced disease due to your screening program at the first test, basically, but then important decreases in these advanced disease. So these are really primary, let's say, intermediate outcome measures, the early evidence that also colorectal cancer screening is making progress and is reducing mortality from the disease in Europe. Again, a review published in the same journal of the European Journal of Cancer on colorectal cancer screening. But as you can see, much more limited evidence at the moment. But still, if we look at the bullets, let's say, in almost all high quality publications, again, we see mortality reductions in colorectal cancer. And then we could make the same kind of slide to basically compare the one program to the other. Again, on the left-hand side, there would be 36 individuals dying from colorectal cancer. On the right-hand side, this is being reduced to 24, so 12 less out of 36 due to a screening program for every 1,000 women, and let's be clear about that, for every 1,000 women in the Netherlands in this case. We have about 90 false positives and maybe only one person being diagnosed and treated that otherwise would never have had this diagnosis. Again, this is the kind of balance that you are having, and that we say this is a relatively fair balance if individuals know about this and then still decide to go for their program. So the third, cervical cancer, and then I will say a little bit about prostate and lung, and then my time is up for sure. But again, in a review on what is out there, again, this is cervical cancer mortality reduction after attending a screening program in Northern Europe data, Western Europe data, and you see it's in the order of 70%, 80%, 90%, huge reductions by going to a cervical cancer screening program. And of course, we now have cervical cancer prevention, but the screening as such is doing great benefits. If you look at the evidence, that is, you could say, a little bit strange. We have evidence from the north, we have evidence from the west, but there's no evidence in Eastern Europe or in Southern Europe, which we certainly should have to know whether that quality is also good enough, let's say. And then again, this chart, this would be a graph for the Netherlands. Of course, it's good to realize that in this case, women dying from the disease is 4 out of 1,000 on the left, going to 2, so a huge reduction, 50% reduction. But in absolute terms, of course, this is different from cervical and breast cancer. And then, fortunately, there was this SAPIA report, Improving Cancer Screening European Union, that together with the chief scientific advisors, or the scientific advisors for the European Union, I should say, gave advice to the European Council to change the recommendations. And I will give you two examples. I will not go too much on gastric cancer. I hope that will come back in the panel. Because gastric cancer is not for all member states an important, let's say, a high prevalent disease to go for screening. But of course, in some countries it is. Should we extend it to prostate cancer? Clear cut, the evidence on that is clear cut. There's a major European trial showing evidence. And on the right hand, that's on the left hand side, the paper, the graph in the New England Journal. On the right hand side, we try to estimate quality of life years gained if you go for screening. And of course, you could say every time a person is being screened for PSA, with PSA for prostate cancer, there may be some benefit, but at some point in time, at older ages, there will be more overdiagnosis and overtreatment. So at some point, one should really stop with prostate cancer screening. But again, we said this is real good evidence to extend the programs to prostate. And the other one is, of course, lung cancer. Again, two graphs on the left-hand side from the American trial, on the right-hand side from the European trial called the Nelson trial. And they both showed huge, I would say, for this disease, huge reductions in the order of 20% or more by having a low-dose CT scan. And so there is progress on the lung cancer side. I'll show you a little bit on that. Here you see the numbers of individuals being screened in programs at present, Croatia, Poland, and the Netherlands. and Italy may be leading in numbers, let's say, but you see basically all members, well, no, I should not say all member states, but many member states are trying to start with feasibility studies on lung cancer. And we made a prediction published in eClinical Medicine 2024. I will not go into all the details, but it would be nice to look at the graph in the paper. Again, I'm biased. I'm one of the co-authors, but nevertheless, what we now have, we can make predictions what lung cancer screening might do in your country, and that is again important for policy making, for the Ministry of Health, for stakeholders, for patients, for individuals and citizens. So for lung cancer, we are at that stage to basically make estimates for countries based on these randomized controlled trials. I was allowed to give one example of for in the long run. That's a large implementation trial in Europe in 6 European countries with a trial element in it, whether it would be safe enough to maybe go for a 2-year interval instead of a 1-year interval if your first scan is negative. If you have a CT scan, your baseline scan is negative, nothing suspicious, then maybe your risk in the nearby years is not that high so that you can go for a 2-year interval instead of a 1-year interval. And that again is a project granted by Horizon 2020. These are the number of screens in time. So we see a huge increase in the numbers in this trial, and we think we are powered enough. Why are we doing this trial? Here you see that about 77% or so are at very low risk. So those are the ones that have a baseline scan being negative. And again, then we don't know, should we do a 1-year interval or a 2-year interval? And that is what this trial is hopefully showing in the nearby future. I think I'm almost done. I surely want to mention the SOLACE project that we will see in the panel. That is another very important part on the lung cancer screening in Europe. 2 more slides. This is a UK slide. What are we doing with these lung cancer screening? These are targeted lung health checks in the UK. And for the first time, if you look at the black lines is for the most deprived individuals. They have always seen that they were at the worst stage compared to the least deprived. So this is on the y-axis, the amount of early stages. It's in the order of 29%. And by time after these lung health checks by CT, this is for the first time on the right-hand side that you see this black line of most deprived are being now more and more detected at the low stages compared to the least deprived. So I'm convinced, and not only in the lung cancer actually, that we have to screen, but not too much. But I wanted to say screening is likely to reduce socioeconomic health disparities in the EU. And with that, I hope to have given you a little bit of overview for food for thoughts for the panel. Thank you so much.
Thank you very much, Harry, for that great overview of the cancer screening. Next, we have Domenico Fiorenza-Glanzmann. He's a policy officer in the Cancer, Health and All Policies Unit at DG Health and Food Safety, European Commission. Domenico will give a short presentation on EU cancer screening recommendations. And after his presentation, we will see a video on prevention and early detection cluster video, which is the output of the collaboration between the different projects in this cluster. Domenico, the floor is yours.
Thank you very much, Petra, for the introduction and for giving me the floor. I would like to go one step back and recall for everyone the policy background of the Council recommendation on cancer screening. So as most of you will be aware, the overarching policy framework of the Council recommendation, besides the cancer mission, is Europe's Beating Cancer Plan. And under the cancer plan, in the pillar on cancer screening, we have one flagship initiative, which is the new EU cancer screening scheme. It consists basically of three main components. The first one being the Council recommendation, which was adopted in December of 2022, as Philippe already mentioned in his opening remarks. Second, we have the European guidelines and quality assurance schemes covering all the cancer screening types which are included in the Council recommendation. And as a third step, we have the aim to improve monitoring and exchange of data. So the Council recommendation on cancer screening, it's based on the SAPIA report, on the evidence collected in the SAPIA report, which Harry mentioned, and it includes several provisions, several recommendations to member states. I will just run you briefly through some of the main recommendations. So the first one is calling on member states to offer evidence-based and person-centered cancer screening programs, and these refers to population-based programs, importantly, as opposed to opportunistic screening based on a number of basic principles. Then it calls on member states to implement accessible cancer screening programs based on European guidelines and quality assurance schemes, which I already mentioned, and also to facilitate the development and piloting of risk-stratified cancer screening protocols, guidelines, and indicators. Further, it should be ensured that benefits and risks, some of them which were covered by Harry previously, are taken into account and also presented to people participating in the screening process in an understandable way. One should aim to collect, manage, and evaluate data, and based on this data, to monitor the process and outcome of organized cancer screening programs, and to report these results quickly to the public. Then the healthcare staff working on cancer screening should be trained adequately at all levels to ensure that they are able to deliver high quality screening to participants. Finally, a high level of participation should be ensured, however, based on fully informed consent. Of course, nobody should be forced to be screened if they choose not to be. And there should be equitable access to screening. Then novel screening tests and methods should be taken into account based on international research results. I think here we can see again very well the interlinkage of the science and the policy side, because obviously first science needs to be there before a new program or a new screening test or method can be introduced on a large scale. And finally, the Commission should report on the implementation of the Council recommendation within 3 years of the adoption, and subsequently every 4 years to help follow up on this recommendation. So as you all know, a Council recommendation is a recommendation. It is not a binding measure. However, through this reporting mechanism, it should be ensured that there's a certain follow-up. So one measure is the reporting requirements. The other one is funding, but I'll come to that in my next slide. So I think the most eagerly awaited part of the Council recommendation was the technical annex. This mostly is based on the SAPIA report mentioned previously. It has updated the specific screening tests and protocols for breast, cervical, and colorectal cancer, and newly introduced provisions for lung, prostate, and gastric cancer, for which further research is needed. So as I mentioned, there's on the one hand the monitoring to ensure follow-up to the Council recommendation. On the other hand, there is funding through the EU for Health program to support member states and other stakeholders with implementing the provisions of this recommendation. One of the main instruments to put forward this work and to put the recommendation into practice at national level and at regional level is the joint action EU CanScreen, which was launched in June this year and runs for 4 years with a new funding contribution of 31 million euro. It has the aim to support, on the one hand, the full implementation of breast, colorectal, and cervical cancer screening, and to test feasibility, to plan and pilot the implementation of the more novel, let's say, less established cancer screening programs for prostate, lung, and gastric cancer. The joint action will have the comprehensive task, let's say, to link the work of all the other ongoing EU for Health projects in the area of screening, also to link the work to the EU Knowledge Center on cancer, and other ongoing EU-funded actions, both under the Cancer Plan and under the Horizon Europe mission on cancer. So I think today's webinar provides a very good opportunity to take stock which projects we're actually talking about, what this joint action should also look into. And I saw that we have also representatives from the joint action connected today. We have some more projects under the screening pillar, which contribute to the Council recommendation. Some of them were mentioned already. Philippe already mentioned CanScreen ECCIS, one of the first projects under the Cancer Plan, which was actually already concluded in February this year, working on cancer screening performance indicators and on a data submission portal to be integrated in the future to the European Cancer Information System, and preparing the work of the cancer screening monitoring report, which I mentioned before. Then we have 3 projects working on innovative approaches for lung, prostate, and gastric cancer. TOGAS, SOLAS, and PRACEU, 2 of them being present here today in the upcoming panels also. And then again, what I mentioned already, the European Commission initiatives on breast, colorectal, and cervical cancer. These initiatives provide a framework for the development of the European guidelines and quality assurance schemes. They are ongoing, and they have already been launched to different levels of maturity for breast, colorectal, and cervical cancer, and will in the future also be launched for lung, prostate, and gastric cancer, to work together very closely with the 3 or 4 mentioned projects and also with the joint action. And then finally, the third EU cancer screening monitoring report, which will take stock of all of the progress which has taken place since the adoption of the Council recommendation in 2022. And I think this was my last slide already. Yes, thank you very much for the attention.
Okay, let's wait for the video to start.
Cancer knows no boundaries. It affects us all, indiscriminately. As cancer has not a single form, but many. Tackling it requires unity, understanding, and innovation. Across Europe, a unified effort is taking shape to support society in this endeavor. The European Union, through its Mission Cancer program, is funding 7 innovative projects in the prevention and early detection cluster. They all have a singular goal: to improve early cancer detection and save millions of lives. Let's take a closer look. First, as a cluster of pioneering projects, we embrace the power of innovation. Europe's scientists and healthcare experts are taking technologies beyond state-of-the-art to detect cancer before the first signs appear. In breast cancer research, MammaScreen and ThermoBreast projects will provide comfortable and accurate detection methods. Early detection saves lives. By identifying those at risk, we will be able to act swiftly, increasing survival rates and giving patients a better chance against cancer's different forms. Lucia is dedicated to understanding risk factors to enhance early lung cancer detection. Meanwhile, using AI tools, Dioptra and OncoScreen collaboratively optimize early colorectal cancer screening, considering individual risk indicators. Patients' comfort and well-being are paramount. By leveraging minimally invasive testing techniques, Pancade and Sanguine are at the forefront of early detection for pancreatic and blood cancers, respectively. These methods not only will reduce discomfort, but also encourage more individuals to commit to regular screenings, enhancing the accuracy and accessibility of early cancer detection. Together, we are stronger. Scientists, doctors, policymakers, and patient advocates are working hand in hand, sharing knowledge and insights. This united front ensures a harmonized, patient-focused approach to defeating cancer. Understanding cancer goes beyond the laboratory. The discoveries made and the technologies developed will shape public health policies. They are guiding the way we prevent, diagnose, and, ultimately, treat cancer. Together, these 7 projects forge a new path in cancer prevention and treatment. A path guided by innovation, collaboration, and a relentless pursuit to beat cancer. Join us in embracing this united vision, because every single life counts.
Ladies and gentlemen, the video that we just saw is an example of pooling resources to develop a communication tool. For your information, all of the clusters are asked to produce a video or leaflet within the first year of forming the cluster. Now, we would like to proceed with the first of the 2 panel discussions. The first panel will deal with innovation in cancer screening, new technologies, and it will be moderated by Amanda Drury, who is a Cancer Mission board member. Amanda, the floor is yours.
Thank you, Petra, and thank you for the introduction. So I'd like to welcome everybody and our panel members to our first panel discussion on innovation in cancer screening, new technologies. My name is Amanda Drury. I'm a Cancer Mission board member, and my background is in nursing. And I'm absolutely honoured to be chairing such a wonderful panel here today. So over the next 40 minutes, we'll be discussing innovation in cancer screening, and within this we'll have a sub-focus on citizen engagement and communication, and there'll be time for the audience to come in and ask questions and comment on the discussion here today. During the discussion, just as a reminder, if you wish to speak, please raise your hand, but we would advise if you could please put your questions into the Q&A section of WebEx, please not in the chat because questions will be missed there. So without further ado, I'd like to introduce our panel members. The first of whom is Klaus Pantel, who is the coordinator of PANCAID, a project which is part of the Prevention and Early Detection Cluster Screening. Eric Lucas is a member of the consortium of the EU for Health project CanScreen ECIS, Cancer Screening and Data Management System. And Ioannis Papanikolaou, my apologies, Nicholas, Ioannis, who is a member of Dioptra, the early dynamic screening for colorectal cancer via novel protein biomarkers reflecting biological initiation mechanism, which is a project consortium, part of the Prevention and Early Detection Screening Cluster. Pippa Powell is a member of the consortium of the EU for Health's Project Solace, which is the strengthening screening of lung cancer in Europe, toolbox for individualized approaches for lung cancer screening on a national or regional level. Tamara Hossong Milagri is a president of Avita Association, a cancer charity which is a partner in MammoScreen, and this project is part of the Prevention and Early Detection Cluster Screening. And Xagoras Fotopoulos is a coordinator of OncoScreen. The project is part of the Prevention and Early Detection Cancer Screening Cluster. And I suppose we've had a very brief introduction to these projects through the video you've just seen, but we will have a chance to go into more detail about the projects over the course of the next 40 minutes. So before we start, I just would like to remind everyone what the Cancer Mission clusters are about. As we've heard already, project coordinators from the projects funded in the same call topic were asked to identify areas that they wish to work on collaboratively and to build synergies among projects and conduct joint activities and deliver policy feedback. And in this panel, we have 4 projects from the screening cluster, as I've mentioned, which are financed under Horizon Europe, as well as 2 projects which are financed under the EU for Health programme. So in this panel, I would like to focus my questions a little on the citizen engagement and communication alongside our discussion of the projects broadly within the cluster and clusters. So before we discuss these issues, I'd first like to start by asking each of the 4 cluster projects, what are the benefits of working in a cluster? And I would like to come to Klaus first, please.
Yeah, thank you very much for this introduction. I think in PANCAID we are looking at developing a blood test for early detection of pancreatic cancer, which will be the second most cancer-related death purpose in 2030. And there are also other projects in that cluster that look at the blood as a fluid for early cancer detection and other tumor types. So I can really envisage very nicely that there is a wonderful overlap where we could really encourage the exchange of data, maybe even patient material, and learn from each other which of our tests are specific for detecting a certain tumor type, and which of these tests might be even able to detect several types of tumor in one blood tube. So I think it's a great idea to work together in the cluster here.
Thank you, Klaus. And Johannes, if you would like to share your own experience.
Okay, I was trying to unmute myself, so thank you very much for the introduction. Actually, my last name, Papanikolaou, which sounds pretty hard to pronounce, is the same one that, you know, the famous Pap smear that was one of the first tests for screening for cervical cancer. So I'm really proud to bear this last name and to belong in this group. I represent Dioptra, which is a program for screening and early detection of colorectal cancer. Actually, I'm a gastroenterologist, a clinical gastroenterologist, and I have really enjoyed up to now having the opportunity to work together in such an interdisciplinary team composed of various subspecialties, IT developers, the people from dissemination, biochemists. It's all there, and so I'm very happy. We want to actually, what we want to do is to develop a blood test as well that could discriminate among from one side advanced adenomas and colorectal cancer from other healthy groups or for non-advanced polyps. Also, we intend to, with the help of AI, to discriminate various factors that might increase the risk to develop colorectal cancer, and to develop, if possible, a mobile application in order to possibly intervene into behaviors that might be linked with increased risk of colorectal cancer. So actually, that's how it is, and I'm very glad to be on board.
Thank you, Johannes. And coming to Tamara, I suppose from your experience coming from cancer charity and advocacy perspective, maybe what do you feel are the benefits of working in a cluster?
Yeah, so especially prevention and early detection of cancer are of utmost importance for the sustainability of healthcare systems. So joining forces in a cluster and engaging in joint communication efforts enhance collaboration, optimize resources, improve public engagement, and strengthen advocacy. These benefits collectively contribute to more effective cancer prevention and early detection strategies. So ultimately leading to improved outcomes and saved lives across Europe. It makes just so much sense to me.
Thank you, Tamara. And then coming to Anaxagoras, from your perspective as the OncoScreen coordinator, do you have any further insights to add in terms of where you see the benefits?
Yes, from my side, I totally believe, into the synergies. It's for us, we have participating in many projects, but this cluster is the first cluster that we see as very active. So, and we believe that it can create impact. And I think the different views, the knowledge sharing that we have, the gaps that we can commonly recognize, can lead us to propose joint recommendations. For example, we hear previously Dioptra is going also on CRC. We are also on CRC. So imagine if we go to the same Ministry of Health here in Greece and we propose two completely different recommendations, it will be an issue. So we need to align our voices in order to create a joint impact, especially when talking about same type of cancers across different projects. So these initiatives are of utmost importance, as discussed previously, in order to affect policies and create a bigger impact for EU citizens.
Thank you, Alexandros. So Ioannis, coming back to you, I suppose we see a lot of new technologies being used in each of the projects in the cluster. From your perspective, do you feel this is a new era in screening, or are we still at a very early stage?
Sorry, I needed to unmute myself. So the way I see it, this is a deepening of pre-existing tools that were there, but actually the development is huge because we are testing now more than 5,000 potential markers. So this is a huge advancement compared to other previous works. Also, the cooperation that is throughout Europe gives us a unique opportunity, first of all, to increase our numbers, and this is very important. And I would like to highlight this from a clinician standpoint, that this has always been a weakness in European studies. So cooperation can help us overcome these difficulties. And second of all, it also helps us this cooperation helps us incorporate many diverse populations that are throughout Europe. And so this is not going to be just one project for, let's say, Northern Europe or Southern Europe or whatever. Our wish is to incorporate Europe united, as nicely said in the video.
Thank you, Ioannis. And I suppose I'd like to open this up to the other panel members. If you've any other views you'd like to share, I suppose, in terms of where we're at, how do we go forward from here, perhaps building on some of the technologies that we're starting to see? What are the next steps? I know we haven't heard from Eric or Pippa at this point.
Maybe just a comment from the SOLACE project. So I'm Pippa, I'm representing the screening of lung cancer in Europe, as has been mentioned a couple of times already in presentations this morning. I mean, we're not looking so much at technologies, but more at how we reach people with those technologies. So we are really using the SOLACE project to reach the people that really need the technologies the most. And I think that's a really exciting thing about the SOLACE project, is the approach to find the individuals who'll benefit most. And I think coming together at a European level and working in a cluster as we are with the EU for Health project. So there's SOLACE, PraiseU and TOGUS, who are really trying to share experiences and share approaches in our projects. I think that's a hugely valuable way of learning from each other and reaching the people who need it most.
Thank you, Pippa. And maybe Eric, from your perspective.
Yeah, of course. Thank you so much. I think the CanScreen EKIS project was a great opportunity for us to basically meet all of our partners. And we work, for example, with SOLACE and PraiseU to also take into consideration this new development in Europe for lung and prostate. And as you know, we try to define the indicator, and we were able also to include this new, basically, cancer screening, future cancer screening program. And we already developed the indicator for lung cancer, for example. And I think the idea really is for the, and Federico speak about, for the next third report of implementation, to include these new indicators to be able to measure and to monitor basically the activity and to measure the quality of a program.
Thank you, Eric. I suppose this brings me nicely maybe to my next question, where we start to hear a little more about the technologies used within the projects. And perhaps, Klaus, you were the first person I'm seeing on my screen. So would you mind telling me a little more about the technologies that are being used in your projects?
Absolutely. I think what we are doing, we are actually taking blood samples and we look at all analytes that are there in a blood sample of a cancer patient to actually early detect pancreatic cancer. And that includes circulating tumor cells and tumor cell products such as fragments of DNA or extracellular vesicles, proteins, metabolites. And we will develop a combined biomarker panel that can hopefully discriminate early stages of pancreatic cancer as compared to healthy individuals. And we also look at patients at risk to develop pancreatic cancer. And this is probably the goal for the future, that we do the screening on the individuals at risk and focus on these individuals rather than a population-wide screening. So we also have blood samples from individuals at risk that we can follow over our time and see when is the turn from a pre-neoplastic to a neoplastic lesion. And if we can detect this transition by a blood test, it would be wonderful for early detection of this deadly tumor.
Thank you, Klaus. And Anaxagoras, would you mind sharing some of the information about the technologies that are being used within your project?
Yes, in Oco, actually, we're using 4 different diagnostic tools. 2, we could say, that can be used over the lab, dealing with NMR and circulating tumor cells, while other 2 are working through breath analysis and like a pregnancy test or a self-COVID test, so that you can know positive, negative on whether you have a first indication. So we believe that these are of much importance as we transition from hospital to home in terms of screening, and given that fecal tests are an unpleasant way of screening, at least based on the feedback that we have from the patient. So all of those are about to act in complementarity, of course, with let's say the colonoscopy. We have also a mobile device, so a patient can see the results, can see its individual risk level at his hands through the mobile. We have an AI in order to, let's say, calculate the risk stratification status, because we believe if we have more accurate risk stratification, then we can have more accurate interventions. And as discussed from Klaus, we can minimize a little bit not going to the wide population. On top of that, we have various other tools that are for policy makers with intelligent analytics, or for clinicians with clinical decision support tools, and 2 tools about upskilling, which was also discussed previously in the presentation, about nurse endoscopists and junior colonoscopists, on how we can help them reduce the either along with digital pathologists for histopathological images. This is it.
Thank you, Anaxagoras. And maybe going to Tamara next, would you tell us a little bit more about MammoScreen, please?
Yeah, with pleasure. So the MammoWave device, which is object of our MammoScreen project, may represent a significant breakthrough in breast cancer screening. It's a microwave imaging device that offers safety, comfort, and effectiveness, and it's already CE marked. It is especially beneficial for women underserved by current technologies, such as those with dense breast tissue and younger individuals at high risk. Furthermore, it is an affordable technology, also an important aspect. Anyhow, the ongoing clinical trial involving 10,000 women in several member states aims to lead policymakers to recommend MammoWave as a standard screening approach based on the generated evidence, of course. Therefore, we need to ensure that its benefits are recognized, well communicated, and hopefully integrated into national healthcare systems.
Thank you, Tamara. And I know we've heard a little bit already from Pippa about Solis, but might you share maybe a little bit more in terms of the screening aspect? I know you've discussed already sort of the focus on patient engagement and citizen engagement and who will benefit.
Yeah, so we have 3 specific target audiences, Amanda, within the project. The first is females, so that we know there is a need for more females. They see a bigger benefit from the low-dose screening projects. So we're really looking at how we can increase participation of females in lung cancer screening. And what we've been doing in that instance is liaising with breast cancer screening programs, and that's happening in 10 countries. And we have nearly 8,000 females who've taken part in that screening approach. The second group that we're trying to reach is the hard to reach population, so vulnerable populations in marginalized groups. And for that approach, we're really trying to address language barriers and finding ways for those people to access healthcare who normally wouldn't. We've been using trained mediators and ambassadors, and we've also been using CT screening, mobile CT screening that can go to the places where people can access it easily. And again, in that subset of individuals, we have managed to screen more than 4,000 within the SOLIS project so far. The final group we're trying to really reach are individuals with comorbidities, so with lung conditions that have shown a connection already with lung cancer. That includes patients with conditions such as COPD and cancer survivors. And we've been really working in that subset of the SOLIS project to identify those individuals and encourage them to also take part in lung cancer screening programs. So coming back to Harry's point earlier, we really see SOLIS trying to address the health inequalities and trying to balance out and making equitable access for everybody for lung cancer screening. And we feel that that's really a vital next step in lung cancer screening programs.
Thank you very much, Pippa. And I know, Ioannis, you gave us an introduction into Dioptra earlier, but perhaps maybe if you might be able to speak to sort of how the project is, where it is in terms of its stage of engagement with citizens.
Yes, thank you. So we have our group consists of 8 clinical partners, 9 actually, but I mean 8 hospitals. The 9th is a tissue bank. So we have 8 hospitals. For example, the one I belong to, Attikon University Hospital, is located, is the biggest university hospital of Athens. It's located in, I would say, an underprivileged area of Athens. So what was just previously said about equity and the opportunity for various groups to participate in this is actually spoke to my heart, because this is mostly the patients that we see. And as I said, we are a gastroenterology clinic, and what we do is we do colorectal cancer screening. So all these patients have their colonoscopies performed, and we take blood and tissue from them in order to develop these markers that we want, that are necessary. Because as we know, the biggest problem with colorectal cancer screening is the low participation of the citizens into the various screening projects via colonoscopy. It's pretty natural that not so many people are keen into having a colonoscopy. So if you have a marker that will advocate, that will be something like another means of pressure to these people to participate in these programs, we envision that maybe that death, that mortality from colorectal cancer screening can be reduced, and that we have more participation in the screening programs.
Thank you, Ioannis. And I suppose moving on to sort of issues around the sort of citizen engagement with these new technologies, and I suppose, Anaxagos, if I might come to you first, do you think that citizens and healthcare providers will have trust in these new technologies?
Yes, I think if we prove that we have a high sensitivity and specificity, and we make all evidence open and clear to both to patients and to the scientific community, I think they will accept, because what we try to do, all of the projects actually here, is to provide a non-invasive and low-cost technology. So I think as we move in towards a participatory care, patients and citizens would like to know everything. So I think if we provide in a transparent manner all results and everything that we have, where we studied, for which groups and everything, I think this will increase their acceptance.
And I suppose in terms of within your own project, might you have any examples of how you have engaged citizens and maybe managed their expectations around involvement in the research or contributing to that your research?
Yes, if I can say, the representation of citizens in our projects are through our patient and advocacy associations. We have 3 of them, and we engage, except of course for the participation in the clinical trials, as discussed previously. We try to engage them from the day one, early from the beginning, in the co-design activities. With them participating in defining the end user requirements, which are going to subsequently alter the technical requirements, and eventually we have a co-designed system architecture. I think this approach of engagement of the citizens early of the beginning also contributes to the overall acceptance. More than that, we have planned, started also from this year in Lithuania, but also have plans over the next years about design some oncothons where we see the bottom-up innovations, and also moving towards the creation of oncological living labs. I think this is a great idea, and also we discuss it as a cluster, and we think that it may be a nice idea for exchanging ideas, for engaging citizens into this, sharing, for example, best practices among different patient associations across Europe, because not everybody is so active, or there are discrepancies across different patient associations. And we think through co-learning panels that will be part of these oncological living labs, we can learn from each other, we can promote the knowledge sharing across Europe. And I think this would be a nice opportunity, a nice chance on how you can actively engage citizens to take decisions, and eventually this will lead to bottom-up policy recommendations.
Thank you, Anaxagoras. And maybe Klaus, I have a similar question for you. I suppose in thinking, how have you involved partner organizations and citizen engagement within your projects?
Yes, we have also a very active patient advocacy group, the Pancreatic Cancer Europe, and we will actually have a stakeholder meeting with advocates and citizens and other stakeholders, which will take place on the 15th of January next year in the European Parliament. So we are very happy and proud that we can really do that. And the idea there is really to actually inform all the stakeholders and get them together, because I think this is super important for us. I personally feel that in particularly the patients, they really need to be even more involved also in the policy making, also in the question which tests are sufficient enough to be used actually for implementation, and also in the question which tests should be reimbursed. And I think I would be very happy, and I think that with this kind of stakeholder event in Brussels, we are looking very forward to really make this dream become true.
Thank you, Klaus. And maybe just opening this up, if any of the other panelists might like to share their own experiences in terms of citizen engagement and encouraging uptake and trust with the new technologies within their projects, I'd like to open the floor.
Yeah, maybe I can comment, Amanda, from the SOLIS perspective. So I represent Lungs Europe in SOLIS, which is a partnership between the European Respiratory Society and the European Lung Foundation. And at the European Lung Foundation, we're lucky enough to work with organisations such as Lung Cancer Europe, but also we have our own lung cancer patient advisory group. And they've been really key throughout the course of the SOLIS project, particularly in advising on the materials that we've produced for the project. So the posters, the outreach, the leaflets, and I think it's absolutely vital that the people that we're trying to talk to are having the opportunity to contribute to the development of those materials. So there is a wonderful connection with patients. We've done surveys and outreach. We have patients on our stakeholder advisory boards, etc. But I think the challenge we have, and I suspect others will too, is that we're trying to speak to citizens quite often who are not yet patients. And I think the approach there is quite different. What we try to do in Solis, as I mentioned earlier, is use ambassadors and also local groups, such as those working with the Roma populations in Hungary, and really training up ambassadors to be able to go into these communities and really understand the needs of the individuals that we're trying to reach. So I think it's a real mix of strong patient organisation and patient involvement, but also realising that the population that we're trying to reach are probably those that don't engage at that high level, and making sure we find grassroots ways to have conversations with them and engage them in it.
Because I think that's a real challenge when you're dealing with sort of cancer screening and early detection, is really trying to take public health in a different way, I suppose. And I suppose maybe Tamara, I might come to you next. Maybe speaking in terms of your own role in MammoScreen, could you tell us a bit more about your involvement?
Yes. So as you said, we are happy to be a partner of an incredible consortium under an excellent leadership by Toscana Life Science Foundation. So in MammoScreen, Evita engages citizens in the MammoScreen project through a comprehensive and multifaceted approach. But we are talking about prevention and early detection. So we are trying to reach a population that is not very much afraid of getting ill, because everybody thinks it's always the others that get ill. So it's not an easy task. So we need to be smart on that. So we are really very much focused on the patient and public involvement and engagement, PPIE. We collaborate in Work Package 5 about PPIE and the patient-facing app development, where Elaros, our partner, is the work package leader and Evita is the task leader of the task 5.1. This task aims to ensure that patients are involved and engaged in the design of the digital interface from the outset, which will support the patient journeys with the experience with a MamWave device. So we facilitate engagement through virtual and in-person workshops aimed at involving patients in the design process of Elaros patient-facing app used for the MammoWave system. So last May, we held a workshop, a very special workshop actually, on how the app will complement MammoWave in the fight against breast cancer. We asked for the collaborative discussion around the MammoScreen project, focusing on the app development. Our aim was to bring together patient advocacy groups, so umbrella organizations, advocates, and also women in general to the project, irrespective of their history with breast cancer and demographic backgrounds, because we mainly need also to address the future user of the device, right? So the workshop's essence was part of the co-creation process of the app that truly mirrored the diverse experiences and needs of all women. We want to make sure that it resonates deeply and serves its purpose effectively. So leading Work Package 7 regarding communication and dissemination, we, and with the collaboration of our manager, TLS, we focus on effective communication with various audiences to ensure that project results reach the appropriate stakeholders. We co-created our project website that serves as a hub for information, including downloadable resources and results. We developed a strategic social media presence to engage a broader audience and share project updates. Don't underestimate social media that have a really huge outreach to reach to any kind of stakeholder. Then we also produce a regular newsletter. Actually, we have a quite impressive outreach on social media. That's a fact. Besides that, we conducted successfully a stakeholder workshop in Lisbon also this year, which involved key stakeholders from national and European levels. The meeting served to foster collaboration and dialogue among stakeholders, including patients, healthcare providers, and policymakers, of course. We shared insights and gathered feedback on the project developments. Patients feel empowered because we are giving them a voice in scientific discourse. We maintain connections with relevant European fora and initiatives, ensuring that project results are disseminated effectively, engaging with all involved stakeholders. In that way, we raise awareness of the project's significance and we facilitate public discussion and debates on cancer-related policies.
Thank you, Tamara. I suppose that's a really comprehensive approach to patient engagement and really getting to the point of meaningful engagement, meaningful involvement and dissemination. Eric, if I might come to you, I know you've told us a little bit about CanScreen ECIS already, but I suppose from your perspective, how do you feel the project will improve the quality and coverage of cancer screening programs in Europe? And maybe if you have some insights around the sort of citizen engagement piece as part of that.
Yeah. Thank you so much. First of all, I think citizen engagement will be fully part of this project because, as you know, we want to share data on a transparency basis, and all the data will be published on the Joint Research Center, JRC. And the idea is really to share all the policy in place in Europe, in all the member states, and basically to share all the indicators also publicly for health professionals, for policymakers, but also for the citizens. So the difficulty in the project was to make sure that everybody speaks the same language and to be sure that we are able to harmonize all the indicators and all the, basically, the information that we will show to the citizens. So basically, we organize a huge number of workshops with active participation of 70 experts from 23 European countries to ensure that we are all able to speak the same language to translate basically the output on the final data. And so we set up an information system to be able basically to collect the information. So we are interested in the policy. So it means the program characteristic, like the protocol, the organization, quality assurance process, but also the quantitative data. And quantitative data are more challenging because we should ensure that we are all speaking the same language when we speak about target, also positivity or further assessment, and etc. So everything was discussed with the experts to ensure that we are able to translate that and that we are able to capture that. And we provide also some analytic visual tools to map the data that we have collected. And the data operator or data provider were able basically to highlight the gap and to basically compare and make the data comparable between all the member states in an harmonized way. So to ensure that all the indicators that will be calculated will be basically comparable and that will be able to appreciate basically the performance of each program. So I think it was something very important for us, and it's a way to improve and to understand the quality of the program, to identify the current missing gap in the core cancer screening program element, and first facilitate and informed decision-making on whether the health system for a specific country or region is currently capable of funding a new cancer screening program, for example, or a new screening test. So we develop and pilot this new approach with this strong data management system prior to its integration into the EKIS. I think the CanScreen EKIS project would pave the way for preparing the third and future report on the status of implementation of the Council recommendation on cancer screening. And we believe that regular reporting values of a key performance indicator from program following integration of the warehouse to EKIS will support development of a uniform standard and quality assurance requirement and will ultimately contribute to the improvement of cancer screening services across Europe in 3 key areas: access, to improve the coverage, the quality, and the diagnostics.
Thank you very much, Eric. So I have a couple of final questions, but I might open the floor to our audience if we have any questions. And I think we had a message that Yuval would like to join.
I think I'll save my words for the next session.
Okay, no problem. My apologies. So Justine, do we have any questions from the audience?
Yes, thank you, Amanda. Yes, there have been some hands raised and indeed questions in the Q&A. But first, let's ask the participants who raised their hand. So I see a raised hand by Oslo McDonald. I don't know if you still want to jump in or raise the question, but the floor is open for you.
Özlem, your microphone is open. You can raise your question. Maybe we can move on to the next participant.
Yes. And if later on, Oslo, you can also put your question in the Q&A, and then we can come back to you via this. The other raised hand is from Meitana. So if you open the microphone, then the floor is yours. I see that the microphone is blocked. I don't know. Abigail, if you can.
Meitana, your microphone is open. Please don't mute yourself. You are muting yourself. Please don't mute yourself. You just have to speak. Your microphone is open. She may have an issue with the microphone because we cannot hear her.
Maybe if we have questions in the Q&A, and if there's any audience questions, if people would like to raise their hands, we can come to them.
Yes, let's do that. If that's not working, then please hear the same. If you can put your question in the Q&A, we can come back to you via this. So in the Q&A, Kaya Palm raised a question directed to Klaus. So Dr. Pantel, if you could comment on the affordability of multi-omics testing and strategy to screen as many as possible.
Yeah, thank you very much for this question. I mean, I strongly believe in multi-omics screening because I feel that we have to detect different aspects of early cancer development. There is the aspect that we can detect a cancer signal, for example, the DNA or some other cells or products from tumor, but we can also detect some host response to the early development of cancer. And I feel if we tackle this with a multi-omics approach, we don't overlook any of these aspects, and we may develop a test that is sensitive and specific enough to detect cancer at its earliest stages. And in pancreatic cancer, it's really necessary to get the earliest stages before the cancer spreads and is so deadly.
Thank you, Klaus. So I see we have a hand raised from Maitan. I think your microphone is open. Okay. I'm not sure if there's technical difficulties with the hands raised and unmuting, but if anybody has questions that they'd like to add into the chat, I think we can follow up on them in a moment. Maybe just to move into our final questions is really around sort of building the communication. And I suppose from any of you on the panel, if you'd like to volunteer your own experiences, but what do you think is the benefit of communicating together through the cluster? Or have you met any challenges in designing common communication approaches? I think we've heard some really nice examples of how citizens have been engaged and how the information is being shared back to the citizen. But perhaps to look at it from the other side in terms of what have been the benefits to the cluster and perhaps challenges within the cluster itself.
Yeah, maybe I can make a start. I think one of the challenges is really that we would love to exchange data or even samples, and particularly data, but we have very strong GDPR rules, and it really takes us 12 to 18 months to get the paperwork done, which is really some time that we lose and cannot really do the scientific work in favor of the patients. So some of these regulatory hurdles, I think, actually prevent us from exchanging data and performing our work as a team, which is a bit sad in my view.
Thank you, Klaus. And I think, did I see Pippa, your hand up?
Yeah, I mean, from a communication perspective, our cluster with Praise You Togus and Solace are planning an end of project joint summit. So the aim is that we'll all come together at the end of our respective projects to really share our experiences, best practices, you know, compare and contrast the different disease areas and the different screening approaches. And I think that's really going to be beneficial because we're all in different places. We've all got different challenges and hurdles, and being able to bring those projects together and have that target for the end of the project to really see how we can bring those learnings to policy is going to be hugely valuable. So we're looking forward to that and building up to that and meeting regularly to ensure that we're aligned on that approach.
Thank you very much, Pippa. Eric or Ioannis, Tamara or Anaxargos, if you have anything you'd like to add.
Yeah, regarding the coordinated communication strategy in the cluster, I think that ensures that messages about cancer prevention and early detection are consistent and impactful, which can enhance public awareness and understanding. Again, we are trying to reach a population that is convinced that anybody else will get cancer, but not them. So that's a difficult task. Joint communication efforts amplify and reach of each amplify the reach of each initiative, making it easier to capture the attention of stakeholders, policymakers, and the public. And a united front enhances advocacy efforts for funding and policy changes, helping to prioritize cancer prevention and early detection at national and European levels. So with collaborative communication, we can better engage patients and the community, ensuring that their voices and their needs are reflected in our initiatives.
Thank you, Tamara.
If I can, if I may, I would like to add on top of this that we believe that also that joint communication can help citizens perceive the message that we have to give as EU projects in a more easy way. What is the difference between OncoScreen, Dioptra, or the projects that we discussed? For a patient or a citizen, it's very difficult. I mean, to read every single project and so on and discover all the details. But when we go as a group of projects and we try to communicate what actually we want to achieve here, I think the impact that we have is better. And this is at least the feedback, some early feedback that we have received from our patient advocacy groups.
Thanks, Anaxargos. I see Ioannis has his hand up.
Yes, thank you, Amanda. I'd also like to highlight and stress what initially Klaus pointed out, that from our standpoint, that it is very important to exchange experiences, because I think that no one of us is participating in a project that is without any hurdles or any difficulties. And exchanging these opportunities to exchange experiences are valuable. They can help us enrich our own experience and our approach to these difficulties. And so I think that this is a great opportunity. Also, being a medical scientist as I am very, very enthusiastic to hear what's actually going on other fields and not only in colorectal cancer. For example, pancreatic cancer is actually one of my major interests clinically in my everyday work. Yes, Klaus. So I am really very happy to see what's going on in this field, which is equally important as colorectal cancer is. So I think that this is one of a very nice and very valuable opportunity.
Thank you, Ioannis. And Eric, maybe from your perspective.
Yeah, I think it was very important for us to have bridge between the different project launch, because we really want not duplicate efforts, but really take the best of each project and try to go in the proper direction in a logic way and in a compatible way. I think for us it was very important.
Thank you, Eric. And Justine, if I'm not mistaken, I think we have a final question from the audience in the chat or in the Q&A. My apologies.
Yes, correct, Amanda. The question is directed towards Eric Ducasse. So for you, can you maybe explain further how are you going to support countries and other stakeholders to know if they can fund screening programs?
I think our project was really here to identify the gap on the current, basically, failure of a program. So we identify 18 core elements in a screening program. And with our tools, we are able basically to map the missing elements. So first, knowing and measuring the current issues in the program can help a country to improve the program. Of course, we are not a funding agency, but we are here to provide some guidelines and recommendations. And with the help of the EU Commission and our country network, knowing that there is an issue in a program, we can take the experience of other countries to really provide some guidelines and recommendations to improve the current issues. So I think it's a common effort to reach basically quality level, and I think we are here basically to help and to try to identify the issues, to improve and to make a quality program.
Thank you very much, Eric. So I think this brings us to the end of our session, and maybe if I might take a moment to come to each of our panelists, if you have any final thought on the session. So I may start perhaps with Klaus, if you don't mind. I apologize, you're the first on my screen.
No need to apologize. You know, I think it's really my pleasure to be in such a cluster. I think it's really a wonderful idea because, as has been said, it shows really the community and the citizens and the patients. We are all working together as a team on this important goal. And teamwork is essential for human beings to achieve goals. So I think it's a wonderful opportunity. Thank you
so much. Thank you, Klaus. And maybe Eric, if you would like to share your final thoughts.
I think measuring the progress is something very interesting, because when we launched the first implementation report several years ago, it was just the beginning of a national cancer screening program. And we have seen all the progress done in the EU community because we were able to measure and to improve. So I think measuring and improve based on the data collected is something very important. And I think we are in favor to continue this mission.
Thank you, Eric. And then coming to Johannes.
So once again, I'd like to stress and highlight cooperation, opportunity to exchange experiences, and to discuss difficulties and how one can overcome them. I'm personally very glad. You know, actually today I'm in my hospital working on, I'm on call, but I was very happy and proud to have participated in this meeting. So I think it was really something more than just a typical meeting. It was very practical and very important for the future of all our projects. Thank you very much.
Thank you. And then coming to Pippa.
Yeah, I mean, echoing everyone else's comments, really, I think it's been, for Solace, fantastic to be able to bring the experiences of 13 countries together, really learn from each other, and gather momentum for lung cancer screening implementation, but also working together with Togus and PraisU and sharing best practice. I think our plea would be, let's make sure this is sustainable, that we don't lose the knowledge, the progress that we've made. Following on from Eric's point, we need to monitor, we need to see how these programs develop, what the long-term follow-up is of some of these individuals. So I was happy to hear Dominique mention earlier about follow-on funding programs, and we'd be, you know, we're delighted to carry on engaging as the Solace project in making lung cancer screening something that really impacts the lives of people moving forwards.
Thank you, Pippa. Anaxagras, if you'd like to share your final thoughts.
Yes, I would also like to add that the cross-fertilization of synergies across project, I think, prove us why such initiatives like the one that we have today need to be repeated again and again, because I think we show what each project can do, and we look for the future, we look what impact we can have, how new synergies can be born, and actually this will lead eventually to our bigger target on saving European citizens' lives.
Thank you, Anaxagoras. And Tamara, I'd like to give you the final words.
Thank you so much. And very shortly, because I see already somebody looking at us because of the time. So I think it's all about joining forces and amplifying the impact of each initiative. And it's also a little about breaking down barriers, you know. Everybody is working in their silo, and this collaboration widens the network and improves also European-wide collaboration. It's awesome, and better times will come for future cancer patients for sure. Thank you very much for your work.
Thank you so much, Tamara. I'd really like to thank all of our panelists for the discussion today and for their time. And I think we have another panel coming up after a break, which will be really enriching. But just to close this session with a very sincere thanks, and thank you to our participants in the audience as well.
Thank you.
Yes, thank you very much. We will now have a 5-minute coffee break before we go to the next panel. So please come back around 4. May I ask you not to log out, just to avoid connection issues, and just turn off the camera and microphone. See you back at 4. Thank you.
The floor is yours.
Thank you. Welcome back, everybody. We will now continue with the second panel, which is about early detection of cancer. The moderator for this panel is Dr. Lina Tolma, who is a Cancer Mission Board member. Before I start with the panel discussion, I want to remind you again that you, the audience, will have the opportunity to participate by putting questions in the Q&A panel in WebEx or by raising your hands. As we have 20 minutes for audience participation during each panel session, also now, we may not be able to answer all your questions or allow everybody to speak, but we will try to come in writing after the webinar. We ask you to limit your questions and comments to the theme of the webinar or the panel contents. Lina, the floor is yours.
Hello, everyone. My name is Eleni or Lina Tolma, and I'm a member of the Cancer Mission Board. And my background is in public health. Let me introduce you first to the panel members for a discussion on early cancer detection. In this panel, we have the pleasure to have representatives from different projects. 2 projects are from the screening cluster financed under Horizon Europe. 1 project financed under the EU for Health program, and there is also a Horizon 2020 project and the national project. So here are our panel members. Paolo Giorgi Rossi, who is a member of the Horizon 2020 project, my PBES, which stands for My Personal Breast Screening on Personalized Individual Risk-Based Breast Cancer Screening. Then we have Henry von Papo, who is the coordinator of the EU for Health project PRAISE-U, a smart early detection of prostate cancer. Then we have Yuval Ebenstein, who is the coordinator of the Sanguine Advancing Early Detection of Hematological Malignancies through the development of a state-of-the-art blood test project, which is also part of the Prevention and Early Detection cluster. Then we have Kadir Guduku and Nida Sinsoy from Emoda. Emoda is a health software development services. It's a partner in the Lucia project, which stands for Lung Cancer-Related Risk Factors and their Impact Assessment, which is also part of the Prevention and Early Detection cluster. Then we have Maria Rikova, who is the representative of the Improving Cancer Care Coordination and Screening in Latvia and Slovakia, or ICCS project, which is funded by the European Commission and National Ministries of Health to develop strategic plans and roadmaps in collaboration with national partners to help reduce cancer mortality in Latvia and Slovakia. Then we have Anna Worm, representing the European Institute of Innovation and Technology, EIT, Health Knowledge Innovation Community. The EIT is an EU-funded partnership that supports entrepreneurship, education, training, and capacity building, as well as innovation. And finally, we have Professor Harry Jakonik, who is our keynote speaker today. He's a professor of public health and screening evaluation at the Erasmus University in Rotterdam, and who coordinates the H2020 Following the Land Grant project. So dear panelists, I would like to welcome you to the second part of the webinar, and thank you to agreeing to be part of this panel discussion. Okay. So in this panel discussion, the overall theme of the questions is on barriers to early cancer detection and addressing inequalities. And inequalities is one of the common activities of the cluster. An example of inequalities include recruitment of participants to clinical trials, inclusion of hard-to-reach population of participants, and accessibility to early cancer detection. So first, I will ask each one of you to tell us, from your perspective, what are the barriers to early cancer detection? However, before I do that, I would like to ask Hendrik to tell us the difference between screening and early cancer detection, as this difference might not be clear to everyone. So Hendrik, the floor is yours.
Screening is targeting an asymptomatic, unsuspicious, healthy individual where we want to find cancer early. So typically screening is a population-based, or it is targeted at certain risk groups. When I think about prostate cancer, this would be African Americans, BRCA2 gene mutations, and those things. At the contrary, early detection is different. It aims at identifying a cancer at an early stage in individuals with or without symptoms, but most of the time it comes down to recognizing early signs of cancer. Recognize them as soon as they appear. An example is peeing blood, having blood in the stool, coughing, weight loss, and those things. So screening is actually proactive, while early detection is often done after the first symptoms. So it's important to know, as an example, prostate cancer is asymptomatic. So it's not a disease prone or exposed to early detection. This is a disease that needs to be screened for, as you might understand.
Okay, thank you. Okay, so let's go around the floor around the room and just ask the simple question that I had before. What are the barriers to early cancer detection? So I'll start with you, Paolo.
Hi, thank you. I see two kinds of barrier in early cancer detection. One comes from the inappropriate offer of the services by the health service. So whatever is in screen, unorganized screening, or in early detection of symptomatic or asymptomatic individuals, the system is not able to offer properly, in an effective way, in a way that can be easily understood by the people, how to assess to access to the service. And the other is the lack of participation or the lack of awareness, according if we are in an organized and inviting an activity, inviting screening program, or if we are in only in early detection. But these two factors both increase the inequalities or decrease the ability of a screening program, if we are in a screening program, to reduce inequalities, because they both have the same difficulties in reaching those that more need the most. Because the lack of participation is based mostly on mistrust in the system, in the health system, and a weak health system increases the mistrust and is not able to produce effective and easy to assess to address the services. So I think all the barriers increase the inequalities, but they are all actionable through a more trustable and effective health service.
Okay, thank you. Yuval, from your perspective?
Yes, so our project deals with blood cancers. Blood cancers do not have a screen, and therefore we are only based on detection and hopefully early detection. And what we found in our analysis is that there are two main bottlenecks. One of them is the family doctor, or the first physician that encounters the patient. Usually, testing is only performed by a specialist. It means that a patient has to go through a process until he gets even to the position where he may be asked to take a test. In general, I have to say, doctors don't like tests. I can say this in a very general way. We are always engaging with the doctors that do like tests. These are the kind of physicians that are participating in these kind of programs. But from our analysis, the great majority of physicians, especially family physicians, do not like testing. And the second challenge is on the patient side. So it turns out that patients don't like being tested. And this is again another challenge and another bottleneck. And especially before you have symptoms, usually you need a very special incentive in order to make the effort and test yourself. This, of course, also goes into the inequality factor, because it seems that the weaker the population, the more resistant it is to testing, and the less accessible testing it is to that population. And we are trying to address all of these issues.
Okay, thank you. Henrik?
I'm an onco-urologist, and I would give what I think about the barriers to early detection and screening in prostate cancer as an example. We have the PRADES-U project that we will talk on later on smart screening for prostate cancer. We have in Work Package 2 performed a survey with the BEST, and you know, BEST is the abbreviation of Barriers to Effective Screening Tool. And we have had 410 respondents from more than 50, I think 55 countries. And the number one barrier actually to early detection and screening for prostate cancer was said to be the lack of political support. And the lack of political support not only from the government, but also from medical societies and, for instance, from general practitioners who are still not well informed about the progress that we have made with novel tools today in the screening programs. The number two was mentioned as being the lack of uniform guidelines. People get information that is 100% contradictory with another one because there is no guidelines yet, and for sure Harry de Koning and others know that we need to establish these guidelines in the next future, not only for the three cancers already ongoing, but also for the newcomers. The number three, and for prostate cancer specifically, was the lack of awareness amongst the healthy male population. Men are different from women. They care less about their health. They do not talk about their health when they are sitting together. They are probably more ignorant about health than their female counterparts. And then the last one we found is the misinformation that men get about the consequences of treatment. So they do not want to be diagnosed, not even early, because they fear the consequences of the treatments, be it radiotherapy or radical prostatectomy, eventually incontinence or impotence, while not realizing that when they're detected too late, they will have hormonal treatment, they will be castrated, the quality of life will be much poorer. So it's a misconception, misinformation that people get through media and so on. So these are the 4 barriers that we saw for prostate cancer, actually. Thank you.
Okay, thank you. Maria, from your perspective, through the ICCS project?
Yes, so as it was said already, I see barriers on both sides. So there is a barrier on the population that is targetable, and also the barrier on the system. And I myself am an oncologist, and I see, for example, that a patient with some type of cancer can have really a kind of a barrier to be screened for other cancer, and it's sometimes it's hard to understand why. But if the patient or if the people have enough information, it's and it was already said here that well-educated population is more prone to go to the screening. So I see the mindset and education on the side of the screen population, and then the system. If the system is well organized, if there are no, for example, barriers, as it was said, for example, to getting to the screening, to get results, to go to, for example, some more advanced diagnostic, if the test is positive, then there is less barrier in the system. In Slovakia, we were lucky to get involved in this improvement of cancer care coordination and screening project, because we felt that it's a good opportunity to improve quality of screening programs, and we asked for support in 2 main areas, and it was increase participation in the screening program through raising awareness. So we got together from like patient organizations, National Oncology Institute, Ministry of Health, and insurance company to communicate screening programs in unified way, and we think that it was very helpful. And then other part in this program or project was to improve data flow. We had a problem in monitoring the program, and then to evaluate it in a good way. And this might be also a barrier if you don't have a good data, then it's maybe more difficult to make correct health policies for the country.
Okay, great. To save some time, I was wondering if there's any other thoughts regarding barriers from the other panel members. Otherwise, I'll go ahead with some individual questions for your projects.
Maybe if I may, it's just like a half minute.
Sure.
So I think we have to make a bit of a distinction now between risk-based screening and non-risk-based, although everything is risk-based, of course. But what we mean with that is that we invite individuals based on their age, for instance, for the breast and the cervix and the colorectal until now. And there, I think indeed the governance of these programs are crucial, as been said. If you don't have a good governance to invite individuals, they will not come. And in the risk-based, I think for the future, things will change. And for the risk-based, of course, a barrier could be how to assess the risk, how to do that, how to get these individuals in. So I think there are 2, let's say, different things for the future.
Okay, thank you. Okay, so now let's go back and I'll ask a little bit more specific questions to each one of you. Paolo, your project, MyPBS, aims to compare to screening strategies, the age or standard screening versus the personalized risk-based screening strategy. You've already recruited 53,000 of the planned 85,000 women. So can you briefly tell us about your project and how is the project expected to improve the care and breast screening strategies, and how is the project going to contribute to early cancer detection?
Yes, thank you. MyPEPS is a trial, an international trial involving several countries. We recruited in 6 countries in Europe and Israel, and it is comparing the screening standard, the standard screening for breast cancer as we are doing now in these countries, with a personalized, with a re-stratified screening actually. And the rationale is, as Henrik Koenig mentioned in the first lesson this morning, this afternoon, screening has benefits and harms. And there is a balance between the two. A re-stratified screening try to optimize the balance, because the rationale is that the benefits can only be obtained by people who will have the disease or already have the disease, while the harms of screening often are experienced by all the people that will receive the test. And so the probability of false positive, the radio-induced cancers are for all the population that has been screened, while the benefit, early detection and so reduction in mortality, can only be enjoyed by women who will have the disease. So in a high-risk population, the benefits will increase while the harm remain the same. So we can apply a more intensive screening trying to get more benefits, while in low-risk population we cannot, because we will increase the harms without having any possibility to increase too much the benefits, because there is no disease. So this is the rationale, but it is not obvious that it works. And so we need a trial. We need a trial because we don't know if really we can intensify the screening and getting more benefits. We can intensify, and maybe we cannot, we do not have more benefits. So we can be sure that we can be more efficient, but we cannot be sure that we can be more effective. And this is why we are doing a trial, a randomized trial. And in the re-stratified screening, we collect information about family history, screening history, and age, obviously, is one of the determinants of the risk, breast density, and polygenic risk score based on a 313 single nucleotide polymorphisms. And on the basis of all this information, we classify the women in 4 groups. And the very low risk group has a risk that is below the threshold for which we decide to screen. So it's below the average risk of a woman at 40 in Europe. So an age for which screening is not recommended. So we can say to the woman, you have a risk that is below the risk of a 40. And in this woman, we never recommend screening. So come back in 4 years and we will evaluate again. And in the average risk, we have the same protocol of standard screening, 2-year mammography. And in the high risk, we have intensified screening with a 1-year mammography. And in the very high risk, that is comparable with a risk of a BRCA2 mutated woman, so it's more than 6% in the risk of cancer in the next 5 years. We propose a yearly MRI. So then there are also other modification of the interval, but this is generally the scheme. We finished the recruitment with 43,000 women, and now we are following up them for at least 4 years to have the final outcome. That is the reduction of advanced cancers. So we will compare the advanced cancers occurring in women that have been screened according to the SARNA protocol and women in the risk stratified screening. We also collect information about the anxiety induced by the knowing the risk, and we have quite reassuring results for the moment. And we also try to have an equitable access to the screening. To this personalized screening. This is very difficult because it is a complex message, and this can be not attractive for all the women participating to screening. So this will be one of the other implementation research linked to MyPEPS.
Okay, thank you. Hendrik, your project is the PRAISE-U project, which is aiming to reduce maternal mortality caused by prostate cancer through smart early detection. What is smart early detection, and how you can achieve morbidity and mortality reduction?
For the question, prostate cancer is the #1 male killing cancer, is the #1 male incident cancer, and is #2 or 3 killing cancer in the European Union. And we know that screening decreases prostate cancer mortality. Not overall mortality, that's not the debate. Reduced morbidity is maybe more important because the quality of life of early detected and treated cancer is better than those that are detected too late, as I already said earlier. Now, the problem with PSA screening was the overdiagnosis. And we know from the randomized trials that if you do biopsies in every man between 50 and 70 who has a PSA above 3, you do biopsies on him, you overdiagnose. This means you detect indolent, insignificant cancers, low-risk cancers in more than 50%. So this made a very bad reputation of PSA screening. And since 2012, from the United States and later on in Europe, this has led to a recommendation against the use of PSA, a real propaganda. Now, in the PRAISE-U, we have proposed innovative techniques to, in fact, reduce or minimize this overdiagnosis. Now, what is the smart screening? As you just asked, if your PSA is above 3, you do not get a biopsy. The innovative techniques are the risk calculators first. If you are low risk, you come back in 2 years, in 4 years, or in 5 years for having another PSA. Otherwise, if you are considered at high risk, you first get a multiparametric MRI, maybe a biparametric MRI that is less expensive and less time consuming. And then when this multiparametric MRI shows you are likely to have a significant cancer, only then you get a biopsy. You see the difference between the number of biopsies that we took before and what we do today with these new techniques. So only those at risk will have a biopsy. Then if they have a significant cancer, a high-grade cancer, they can be treated actively in time. And we know that we will still, in every early detection or screening program, detect insignificant or low-risk cancers. But we have identified whom we can follow today very safely with just active surveillance and no active treatment. Now, a very important aim of PRAISE-U is to get back to the Commission in 2026 to show them how population-based screening is best done in the European Union in order to stop what is happening today, and that's opportunistic screening. There's a huge amount of men that are opportunistically screened on the incentive of themselves, on the incentive of the GP, and this leads to a costly and ineffective consumption of money. It does not impact on mortality as it has been shown, and it does not avoid the overdiagnosis. And this is what the Commission has very well understood, that to stop opportunistic screening, we need to have these organized programs. And we hope that we can indeed, in 2026, show the way to go further.
Okay, thank you, Hendrik. Now we're going to move to Keder and Nida. You're both working on the EMODA, which is a partner of the Lucia project, developing 2 apps, one for clinicians and one for the patients. Nida, can you tell us first of all about the apps and their purpose? And then Keder, coming to you, The question is, how do you ensure in designing the apps for the project that both patients and clinicians' needs are being met or addressed?
Thank you. Of course, we have developed 2 mobile apps, as you said, one for clinician and one for patient. Both app allows user to take measurement using patch, and you might wondering what kind of patch. Lucia uses innovative AI-driven variable sensing patch called wide biomarker spectrum patch, which continuously and personally detect and monitors cancer biomarker in real time. That is the patch we are using. Patch and phone connect with NFC. So to begin measurement, place the back of your phone onto the patch, then app start measuring automatically, or you can click start button also. After a while, at least 1 minute, removing phone from the patch, stop the measuring, so you can see the result on the phone. If user click save button, we send the data to the data platform for the further analyzing. And additionally, both app has the questionnaires prepared by the clinician, our partner, clinical partner. Patient can complete questionnaires using a patient app on their own at their home or outside any place. And some questionnaire need assist of clinician. So we have questionnaires in the clinician app. Patient then come the hospital center, assisting of clinician, they can still complete the questionnaire using the clinician app. So we have questionnaires differently, both app. And to all summarize, purpose of these mobile app is to serve as a central hub for collecting health data, including lifestyle and environmental factors, which help improve patient data management and support better clinical decision making.
Okay, thank you. Theodore, would you like to add something? Would you like to add something in terms of meeting the needs of the patients and the doctors? Kadir, sorry.
Designing the apps to ensure that the needs of both patients and clinicians are considered and included in the app design.
Okay.
Sorry?
I said, okay, go ahead.
We prioritize creating a user-friendly interface and actively incorporate feedback throughout the development process. We began by adding clear instructions within the app to guide users. After initial testing with one of our project partners, we updated the app based on their suggestions. For example, they requested a timer to display the elapsed measurement time, as well as features to add notes and patches like serial numbers. These updates were implemented promptly to enhance usability. Also, we maintain close collaboration with partners through active communication, including Teams, calls, and face-to-face meetings to gather detailed feedback. Currently, the app is being tested by a small group of users, and their feedback is shaping further improvements. Soon, we plan to involve clinicians in the testing process to address their specific needs and integrate their suggestions into future updates. This iterative and collaborative approach ensures that the app effectively serves both patients and clinicians.
Okay, thank you. Okay, Anna, let's go to you now. What does AIT Health do in early cancer detection, and which projects does AIT Health support in this area?
Thanks very much. I think I have a few slides. If I have presentation, if you can enable presentation mode. Perfect. Great, so thank you very much. So with these slides, I just have them as a backup to follow along with the conversation. But essentially, I'm just showing what EIT Health does in the area of early detection and screening, and also present one of our EIT Health think tank projects that's coming up. So just to give you a slight background on EIT Health, we are co-funded under Horizon Europe. We're a European partnership, and we're a community of world-leading health innovators. So we're one of the 9 knowledge and innovation communities under the European Institute for Innovation and Technology. So that's EIT, which is an EU body. And we're based on the principle of business, research, and education. And as these 3 come together, we work as one, which creates an optimal environment for innovation and moving forward with innovation. So at EIT Health, we try and facilitate innovation through supporting the following initiatives that strengthen healthcare systems, contribute to a sustainable healthcare economy, promote better health of citizens, and naturally oncology and early detection of cancer is included in this. So we have a few programs on these topics, but for the sake of this panel, I'll stick to the ones on early detection. So just to note, to accomplish all of our goals, we have a strong partner network. We rely on the different network partners across the EU. We have 9 co-location centres that can be seen on the map, so the ones in blue, and the area in yellow as well is our regional innovation scheme. And we have a number of different partners across the entire healthcare ecosystem, so that includes universities, research institutes, healthcare providers, and startups. And so this collaborative network, it really brings together the expertise from different centres. So bringing this back to early detection in cancer and why it's so important for EIT Health to work in this area. So under EIT Health, we have an EIT Health think tank, which is effectively a place where we gather the real life insights and experts and from innovators to support pan-European and national policymaking. So this is the platform which we use to identify and prioritize the different real-world insights from a wide range of stakeholders. And we're using this to understand and shape the environment and the key challenges of today in healthcare. So over the last 6 years, we've had a few different think tank reports. Our most recent was on the European Health Data Space, which was launched in April. But for this time, from 2024 to 2026, we're going to be working on early detection and particularly on blood-based cancer screening. Just to be clear, I think to avoid any confusion, when we talk about blood-based cancer screening, we're focusing on the multi-cancer early detection tests. So that's done via a blood-based sample. So those are the innovative tests, the diagnostic tool to detect multiple types of cancers at an early stage using a drop of blood, essentially.
Okay.
And
sorry.
and on the project itself, the aim of the project is to really understand the evidence and requirements for blood-based cancer screening to be included in recommendations and guidelines and in implementation. So we do this through 4 different dimensions. We're still in the early stages of the project, but we would like to focus on the potential for the blood-based cancer screening, the existing screenings throughout Europe, the evidence requirements. So this includes clinical and scientific requirements for blood-based screening, the implementation of blood-based screening. So this would look at the different pathways and infrastructural changes and look at the suitable ways that this could be adopted, if it could be adopted, and the uptake, which is focusing mainly on education and awareness. And then just to wrap up, this is my final slide on the kind of methodology we're going to use. So we're currently in the first phase, which is step 1, which is the preliminary research and the formation of the steering committee. So our steering committee is made up of several experts in this field. And we're now moving on to step 2, which will be the roundtable series. So over the course of 2025 and the start of 2026, we'll have 15 different roundtable series across different member states and countries across Europe, where we'll look into the different challenges and look at the objectives that I showed in the previous slide, and determine what the challenges are around implementing blood-based cancer screening, and the kind of issues that might come up between the different member states. We'll then consolidate all of these into a final think tank policy recommendations and a policy report. And then as a final step, we usually launch the think tank policy report and the recommendations in Brussels. So the first country that we want to start with will be in January 2025. This will be the UK, and I know what you're thinking, that's not an EU member state, but we did think it'd be a good place to start since they do have a few existing blood-based cancer screening trials running at the moment, and this will be followed by several other EU member states. I think those are all my slides, but that was a very brief overview of what EIT Health does.
Okay, thank you, Anna. And because we're running a little bit out of time, I'm gonna throw the question out there, and since the focus is on inequalities, just anyone who wanna address that, how do you address inequalities in your project, whether it's a national cancer screening program like the ICCS, or whether it's a trial, how do you improve participation of hard-to-reach individuals, or how, in general, how do you address inequalities? And you have to be a little bit brief, because I want to leave some time for questions. Who wants to?
If I may, Elena,
Yeah.
inequalities exist in prostate cancer screening simply because it's opportunistic. And opportunistic is the wealthier people, is the better health literacy people that come. And the only way to circumvent this is to have an organized screening where all men between a certain age category are invited, unaware of their social status, their health literacy. They are invited, informed, they can get to their GP to get more information, they get a surface mail, they get a telephone. So that's the way we need to work, and this will end the inequality that we have in prostate cancer screening, like it is ongoing today.
Okay, thank you.
And if I may, perhaps, Eleni?
Yes, go ahead, Harry.
So thanks. So in the For in the Long Run trial, which is the big implementation on lung cancer screening in different countries, we use different ways of recruiting individuals. There's always been the difficulty of reaching the lower socioeconomic class, if I may pronounce it like that. But we really see that we are able to get these individuals in and then make a difference. And I think so we actually did a small randomized controlled trial on recruitment, but maybe just as a key message, we were surprised that people going online to fill in the questionnaire or to fill in the risk assessment really worked. So in the age group 60 to 79, we could have all kinds of thoughts about going online in this age category, but we found that online systems are also working. So I think that is an interesting message for the future, I would say.
Okay, great. Maria, I'm going to put you on the spot. Anything from your experience promoting early detection of cancer in Slovenia through the ICCS project?
Yeah, so addressing inequality was actually also participating in the project, because we try to make more organized screening programs in Slovakia. It was already said that opportunistic way of screening really isn't a good way to go, and we understand that it's important, and we need to have also like ministerial and political support, and participating in the project actually helped us to somehow put all those requirements on the strategic plan and then recommendations from the expert from this project. So it helped us in this way. And now we are in the process to build a national screening center. We think that really to put it on a really organized manner would help to actually help to remove inequalities that exist right now in Slovakia. And also, I think great way is continuous collaboration, for example, in EU Can Screen program to building unified guidelines. As it was said here already, it will help all countries to go in somehow unified manner. And it helps countries where we don't have so much support, or we didn't have so much support in the previous time. So thank you.
Thank you. Okay. So now we're gonna go to the audience from your perspective. If you have any comments, please include them in the Q&A panel. I don't know if I have any questions. And also, I have a question here for anyone who represents the cancer charities. If you'd like to comment on the inclusion of patient voice in cancer clinical research, and what advice you'd like to give to coordinators on how to include hard-to-reach populations.
I can just say something about something that we're trying to do in the Sanguine project. So I think COVID has shown us very clearly that testing can be performed much easier than we would have thought. And we've tried to install this concept of pop-up testing. So with blood-based tests like the one that we're developing for various blood cancers, it's quite easy to bring the test to the people instead of bringing the people to the test.
Interesting.
Yes, and this actually allows to broaden your participant pool as you plan to do. And I think that's a very good concept to adopt overall.
Interesting. Thank you. Okay, do we have any questions from the audience?
Yes, Eleni, if I can jump in.
Sure, go ahead, Justine.
Yes, thank you. I see that we have a raised hand from Francesco De Lorenzo. So we are unmuting you, so you can take the floor. So you don't have to unmute yourself because that's already been done. So you can speak now. No, I think, yes, I think we can hear you now.
It's me? Hello? Is it,
Yes, we can hear you. No, not anymore.
It's okay now?
Yes, we can hear you now.
Okay, yeah. I am president of the Italian Federation of Cancer Patient Coalition, of Cancer Patient Organization. And we are quite worried about the kind of progressing of the member state to follow up the request by the European Cancer Plan, namely to have with the new scheme of the screening to ensure that 90% of people who qualify to the 3 screening will have access by the 2025, because we know that several of them are really much late for this. I wonder whether you have a general idea how things are going in the member state in Europe, so that we can find out how really all the work that's being done and will be done by the joint action and so on will really get the member state to better correspond to the request of the European Cancer Plan, because our position is that very little now is really reaching patient to their own position. So then it would be nice to know what the Commission feels to do and how much we as a cancer patient organization can be in the condition to know how really is the situation in each one of the member states.
Okay, I don't know who wants to answer this question.
May I try a little bit?
Yes, go ahead, Harry.
So indeed, in a very, very fair point, we can make statements, but at the end, the question is, will we make a change? So indeed, in this new action that is being granted, that Domenico mentioned, about 30 million euros to all the member states, we're really going to address that. So to look at the indicators and the coverage of the different screening programs. We have so-called exemplary countries that collect data. And basically, we do think that we hope to be able to show a change in the 4 years time period. So that's at least a way to do it. But maybe you're right that at the national level, of course, countries should maybe do that themselves, of course. But anyhow, I would say in a joint action, it is at least a priority to look at this. Yeah.
Okay, any other question?
There are also some questions raised in the Q&A.
Okay.
And one, I can see that Hein, you already provided an answer, indicating that, for example, the Joint Research Center is working on this. But for everybody in the webinar to hear the answer, I'm repeating the question. So if Professor Van Poppel could maybe indicate and please comment on that the guidelines will always run behind of what new technologies can offer for early detection.
It's indeed effective. I look at the EAU guidelines that we are responsible for. They do not advocate screening today. They advocate, like the Americans, a shared decision making. But again, when you do that, it's better opportunistic screening, but that's all. It's still opportunistic. Inequalities will be maintained. Obviously, what the Commission has done is advised to the Council to change the recommendations on screening and add the lung cancer and prostate cancer, and also gastric cancer to the cancers to be recommended for screening. Now, the guidelines, and certainly the guidelines that are now worked out by the GRC on breast cancer, next cervix, and next colorectal, and prostate will have to wait. Maybe even lung will be earlier than we are. But indeed, we need to follow what the Council has recommended, and it's to pilot in every single member state to see whether on a small population size, not population, but population based in a certain area, a certain region, to do that and then come back in 2026 and report on what we have found out. What's the best way to do it? How do we get people? How do we then get motivated so that we have a better turnout than, for instance, the 2% that we have today in Poland? You imagine you invite 100 men for having a PSA test and there's 2 men who come. There's a lot of things that we need to learn. And when we report in 2026, I'm really sure that at that time, the Joint Research Center will have started to work on the prostate cancer guidelines, and they could be finalized around the same time. For me, population-based organized screening in the EU member states, where it will be obvious that this has impact and reaches its goals, this will be for around 2026, 2028, and not earlier. And in the meantime, we need to do this piloting to see that we are able to set it up, that it's cost effective, what's the psychological impact and all those things. So we will learn a lot from it, report to the Commission, and the GRC will not be so late after the recommendations, new recommendations of the Council, we hope.
Okay, thank you. Do you have any more questions?
Yes, there is also another question from Nikolai, where he says that research in the field of screening brings a specific set of regulatory, socio-political, socio-economic, and ethical challenges, and that these challenges easily can become barriers. And then he indicates that from his experience from the MemoScreen project, is that a huge challenge is ensuring that a project will produce the evidence what is necessary to satisfy an HTA, so the Health Technology Assessment. And only if this is achieved, a new screening approach has a chance of being adopted. So the question is, do we need to work on developing a screening HTA framework?
Okay, who wants to answer this question?
Harry de Koning.
Yes, maybe. Thanks. And why? Because indeed there is a European HTA framework by a European organization that basically led to a framework on HTA, on health technology assessment for the EU. In the new joint action, there is a specific work package on HTA and modeling. So in which indeed with the data from the different countries, we try to make cost effectiveness analysis for the countries for the different screening programs based on their own data. So in that sense, there is a HTA screening framework, let's say. But indeed, it would be good to bring this maybe together to bring this screening, the screening methodology and the HTA framework of the EU together, maybe in the nearby future. That's a good point.
Okay. Do you have more questions?
May I try to answer to Pavlos Neophytou? It made a very interesting question about
Sure, go ahead.
A re-stratified screening for breast cancer and especially for the starting age. Obviously, this is part of the scope of my PEPs also, but it is very interesting to explore this, because we have already a conditional recommendation, a conditional against from 40 to 45, and conditional in favor from 45 to 49. So it is really a situation, a landscape where risk can make the difference in this conditional. What is the condition that should favor in screening or favor no screening? Exactly, the risk probably is one of these conditions. And but the problem is that for starting age, to change starting age, we need to get the information before the woman accesses to screen, any access to the screening. So this is very difficult to obtain in reality, and it introduces a sort of case finding in the early detection, spontaneous early detection instead of screening programs. But there is a very interesting program in Estonia that will use a polygenic risk score for those who are already part of the National Biobank to tailor the screening starting age. I think this is one of the frontier of the next research in breast cancer. Very interesting point. Probably we need some more accurate determination of the risk than just the first degree relative with breast cancer, but probably this is one of the future development of screening.
Okay, well, thank you. Tamara, you have your...
Yes, so I wanted to talk about also the genetic predisposition as a high risk factor for cancer. Actually, it's the highest risk factor to develop cancer. It's 10% of all cancers, also involved in breast cancer, prostate cancer, colorectal cancer. So crossing all the areas. I think we need to do better on the identification of genetic variant carriers, so we can have more targeted, personalized risk cancer screening for these people. It's early onset of disease, so populational screening comes too late for this population, and that would be a very important point. I also want to underline the comment of Hein von Poppel regarding men that are difficult to reach. That is a true thing. That is there is evidence on that, and we need to have a gender-specific communication targeted to this population. We at Evita did a campaign calling our messengers in front of the screen, which are the women, the partners, the wives and the girlfriends. And we wanted to educate about male breast cancer, and it had really a huge outreach because we used messages, because men are running away from this kind of information.
Thank you. Henry, you have your hand up. You want to give a last comment, but it has to be really fast because we have to wrap up.
Can I just come back on what Milagro was telling about the high-risk population? When we are speaking about population-based screening for prostate cancer, men between 50 and 70, This is the target population. If we have a very strong family history in an African American man whose father or brother died from prostate cancer, who have BRCA2 gene mutation, this is not the target population for a population-based screening. This is case finding. They are in the clinic, they are with their doctor, they need to start at 40, 45 to be screened. So the population-based, this is different. The very high risk groups, as Tamara has been saying, they do not belong to a normal screening population. You see what they diversify in breast cancer screening, following the ages and the risks. That's probably what, in the end, we will get to in other programs as well. But nowadays, for prostate cancer, the very high risk do not belong in the algorithm that we have designed. This is patients. This is not healthy population. I wanted just to clarify that. Thank you for your remark, Tamara.
Yeah, I know, I understand. It was really a general comment because it's a transversal problem. I know we are talking about populational screening. Thank you.
Okay, and I would like to thank all the panelists for their contributions. And I know we could continue talking for hours, but unfortunately we have to wrap up this session and also the webinar. So thank you again, and thank you for the audience for your comments and questions. And Petra, back to you.
You're muted.
You are very lucky. Sorry. So I'm saying that we have noted that there are a number of scientific questions which have not been answered today. We will answer them in writing after the webinar. For now, I would like to call on Jan van der Loof from the Cancer Mission to give the Cancer Mission Secretariat to give the closing remarks. Jan?
Yeah, thank you, Petra. Also on behalf of Cancer Mission Secretariat and our board members, Amanda Drury and Lina Tolma, really thank you for everyone for staying with us for 3 hours. I thought it was extremely interesting. This is only our second policy webinar, and we are really improving with these events. So that's my first message, is that the information that you share with us at these policy or these cluster webinars is very important for us, because we are trying to create a feedback loop. So we are trying to create better links between research innovation, public health, and other programs. And so starting with such policy webinars where we bring everyone together and have these discussions on implementation, on the issues that you raised, really helps us to co-create further the cancer mission with citizens, not only patients, but also healthy citizens and citizen risk, with stakeholders, both private, commercial, but also more and more, as you hopefully will see in the future, we also start working with the European Innovation Investment Bank, EIB, with member states and other Commission DGs. So for information on the Cancer Mission, as always, you can have a look at the Cancer Mission implementation website. We also are working on a newsletter. The Joint Research Center, Knowledge Center, they have great information also on their activities. I really would invite you to have a closer look. The Cancer Plan has a very informative newsletter as well. So I think if you want more information, you would just have to inscribe yourself. The Health Policy Platform, for example, is a very important provider of similar information, where we try to post all our events. And I think last but not least, I want to inform you that very soon, early in 2025, that is, we are waiting for Hadeya to inform the winning research proposals that were submitted to the Work Program 2024 for missions. And we are working on Work Program 2025 already. Actually, we are quite advanced, and this is, as always, being done with the member states and associated countries in close collaboration with DG Santé, which is in charge of the Europe's Beating Cancer Plan, and of course other Commission services with a stake in cancer. And we have already started working on the years 2026 and 27. But for this, we really need to co-create and have your input. These policy webinars will also allow us to create this policy feedback loop towards our own Cancer Mission board. So stay tuned. And my last message is that, of course, to come back as Kay mentioned, and thanks a lot to Kay Duggan-Walls for organizing this policy webinar, is that in 2025 we're going to come back with the follow-up event on the prevention early detection cluster, which is going to focus on primary prevention, and you will hear from us. So thank you very much and have a great evening. Thank you.
Thank you.
Thank you.